That was a wonderful, really wonderful talk. I think everyone will agree with me. This is a field that we don't know much about it, but although we're slowly learning more as we start working in a multidisciplinary group, like especially in centers where they have a tumor board and they approach management of HCC in a multidisciplinary way, I'm sure they're more and more engaged with radiation oncologists, and this is a learning opportunity. And a lot of things that you told, I mean, I didn't know as well, and I learned a lot today, and I'm sure everybody will agree with that. With that, I would like to open the forum for discussions. Maybe we can go around the world. We can start in rounds from each country. Maybe we can start from UK. Maybe Dr. Aftab Allah from UK is in King's College London. Dr. Allah, how do you guys approaching managing patients at HCC, and how are engaging with the radiation oncologists there?
I have to say we could do it better. The approach is certainly multidisciplinary, as Joe has outlined. I was interested in some of the multimodality approaches. I mean, we do have a nanoknife that's starting, and I don't know. I had a specific question to Joe on nanoknife and that technology, because certainly my experience is growing on that, and I just wanted to get his words of wisdom on that.
Yeah, sure. So as you know, I do pancreas, or as I mentioned, I do pancreas and liver and other GI. So in the pancreas space, we actually started using IRE probably 8 years ago. And what we would do is treat with radiation, and then at the time of surgery, we'd use IRE to potentiate the effect if the patient was not a surgical candidate. In liver, I think it's still in its infancy. I think I look at it as you mentioned, it's another tool that we could use. I equate it similar to sort of RFA and ablation. Obviously it's different. There are still some heat sink effects you need to be aware of. And then again, in this case, at least I don't completely believe some of the comments around fiducials and some of the issues with fiducials, because it does affect some of the current. But again, is it really that big of a difference? I don't know. But I think ultimately, I do think it's a very exciting addition to the technology, or to the different technology options. I will say that in my institution, so at MD Anderson and Hopkins, we did not use it a lot for liver. So, I'll be honest, I don't have a lot of personal experience. I have a lot in pancreas, but not a lot in liver. And again, again, the results seem to be relatively similar to what you see with RFA, but I'd say probably a little better. And I think it's also a nice option for bigger tumors, where I mentioned where SBRT was maybe superior. At least the literature that I've seen, that IRE might be a little more effective at the larger tumors than RFA. But again, I'll defer to others on this call that might be better experts in that space.
Thank you very much, Joe. That's a very comprehensive response. Thank you.
Thank you.
Professor Chawla, former mentor of mine, Yoga Chawla from India. Dr. Chawla, thank you for joining today. And I'm sure you have a lot of questions.
Sanjay, it was absolutely wonderful listening to him. In Chandigarh, we've been practicing SBRT in patients with HCC, where RFA is not possible. But currently, we have used it in patients with larger lesions. And as has been just said, that you can pick up lesions less than 10 centimeters and you are effective. The biggest advantage which I find is you can go beyond CTP 9, 10, or maybe 11, because the side effects are very little. Maybe one would like to have an opinion from the expert, but I personally find a lot of confidence in treating patients with SBRT from our radiation colleagues.
Professor Dharmesh Kapoor, would you have any differences in the opinion in the management?
Hi, Sanjay. Thanks for giving this opportunity. It was a wonderful talk. So I don't have much experience with this technology. We just started to use it in the last couple of years. And I would say after this talk, maybe one would, get more aggressive in using this therapy. I just wanted to ask Professor Herman, in his experience, do they often get consults for SBRT in patients who do not have vascular thrombosis, that means PVTT? And what is the position of this therapy in patients who have no vascular invasion compared to the other locoregional therapies?
You know, I think that's a really great question. So I've been doing this now for, I lose track with kids, especially with COVID. So 17 years or something. So when I first started with Laura Dawson and we developed the RTOG trial that you see there, it started out with mainly focusing on just portal venous thrombosis, right? That was the one where people would say, oh, we can't really do TACE in those cases. Y90 is not effective. So that was the niche that we wrote that trial about, to be able to have a chance at being part of the team, right? We wanted to have something to offer. And by the way, I'm happy to stay, Sanjay. Like, there's no, I mean.
No, we actually continued the discussion up to 9:30. So it's
okay, great.
fine.
Oh, that's awesome.
Yeah.
Okay, so I don't have to rush. Okay,
No,
all right.
you don't have
Yeah,
to
that's
rush.
good. I'm good. This is fun. This is so cool. So I don't have to rush as much. Okay, that's good to know. I think when you look at the evolution, it's, as I kind of tried to outline pretty quickly, the technology has enabled us to do so much more. So first of all, when it comes to portal venous thrombosis, it's actually very effective at helping, for lack of better words, melt away the tumor over a period of time that, allows the patient. I've seen major improvements in the liver function, but the key is this: the sooner we see these patients, the better, right? I see a lot of times, like MedOnc, and the patients come to us a lot of times so late in the game, like where they're so sick or it's so advanced, or their liver function is already so bad. So I don't want to forget that part. I think the one thing, if there's one take home here, is at least, say, hey, can you take a look at this newly diagnosed patient? I'm probably going to treat them with TACE, or I'm probably going to treat them with this, but just want to put it on your radar. Would you do anything sooner? Or there's nodes over here. Would you recommend, should we actually do stereo instead? Or should we do, a 15 fraction regimen? I think it's always good to just kind of bring them into the loop. But anyway, to get back to your question, those are the patients we primarily treated for, I'd say the early 2000s. But then, I think a couple things changed. One is that the interventionalists were able to actually treat some of these with Y90 and with TACE, and they started seeing resolution, right, of the thrombus. So radiation wasn't necessarily required for those cases. And then I think the other thing is that, we started, so we recognize that in some cases where there's very long, thrombosis that maybe extends all the way up into the atrium, right? It's unlikely that an arterial treatment it can work. I'm not saying it won't, but it's harder to obviously penetrate that far. So those are cases where doing very conformal radiation and tracing it all the way along the path, I've seen some really impressive, incredible responses. But keep in mind, it can still take a little longer, right? It doesn't always happen right away, and being patient. But acknowledging, I see one question there too, but acknowledging, I guess what I'm saying is, it really comes down to having the discussion with IR, with the hepatologist, and saying, okay, do you think you can get all of it? That's what I would always say to them. Do you think, based on the distribution, based on the vessels, based on the vasculature, based on what you see, are you going to be able to get it all? And if they say no, I'd say, well, let me take a shot at it, and then you could do it, or go ahead and do it, and then we can complement it, and I can maybe treat, sort of the extension with stereo. That being said, there's still a lot to be learned, and there's not a lot of trials on that sort of novel integration. But I don't know if I answered your question directly. I guess I would just say that, sorry, the last thing is I don't treat that much thromboses now. The ones I treat more so are actually central tumors where there's lymphadenopathy, like intrahepatic cholangio or HCCs that have nodal disease, because I can cover all of it in the same field, or patients that have already received Y90 or TACE and they have marginal misses, or where it's up in the dome of the liver, or if it's, again, if it's invading into bowel, where they're worried about Y90 and causing complications. So those are the ones where I would say are become more and more relegated to radiation oncologists, not just those with a thrombosis.
That's great. I have a couple of questions, and then I will go again to the different continent maybe. Dr. Sagun Misra, then followed by Dr. Niraj Rastogi. Dr. Sagun Misra.
Hi, I'm Dr. Shagun. I work at HGPGI Lucknow, India. And I had the opportunity to train at Princess Margaret Hospital, Toronto, and also at the University of Pennsylvania. So what confuses me, Dr. Herman, is that regarding the dose-response relationship in HCC, and there appears to be two different schools of thought. Dr. Dawson's group feels that there is no dose-response relationship, and that's why you have the RTOG 11112 trial, where you have different dose schema depending upon the OAR doses that you are able to achieve. On the other hand, you have a school of thought at the UPenn where you think there is a dose-response relationship, and that's why you tend to fractionate more as your size of lesion increases. So what's your view on that?
It's good. It's a really good question. And I'm careful because Laura Dawson's one of my mentors. So Laura and I have worked together for so long, and she's incredible. I mean, she's so smart. She's a visionary, and she's an incredible teacher, the best teacher I would say I've ever had. I don't think there's and I'm not dodging the question. I would say that I don't think there's a right answer. I think there's two things. I would say one is that I think Laura Dawson's approach is important because it's much more quantitative. It's scientifically based, and really what she has always focused on is what we call like normal tissue complication probability, what is the tumor control probability, and using the data of that patient to drive the dose and the response rate. I think the only thing I would just acknowledge though is that the modeling that we're using in those cases may not be completely accurate as we start getting to these ablative doses, right? And I think to your point, so my opinion a little bit, and this is like kind of is that I don't think we know yet, but I would say that for HCC, we're probably over-treating. I think what Laura Dawson's saying is for HCC, we probably don't need to go to such high doses, right? And we're over-treating and we might be hurting patients. On the other hand, if it's HCCs that are more resistant and or like, again, colorectal metastases, I think there's no question we have to go higher. I think the data is pretty clear that there is a dose response and there's certain tumors that we will not get durable responses if we don't go to higher doses. I think the key is the future is going to be biomarker driven, looking at the molecular profile of these tumors, understanding the vascularity. So I think it's neither is right. We need to do better and be more biologically based and base our dose response on imaging criteria, radiomics, and be more personalized in how we approach it. And so again, I'm not addressing your question directly because we don't have enough data to really say who's right or who's wrong. I think it's both are right, but we need to decide which patient we should be doing which with. And I think that over time, that data will continue to evolve and emerge. And we will become much more personalized in how we approach it.
Wonderful.
Thank you. And one more question as to
Sure.
what's your take on concurrent sorafenib with SBRT? I think.
Yeah, I think, I mean, to be honest, in our practice, and Sanjaya can comment, we don't even, sorafenib is I would say more of a salvage treatment. I mean, it's really not even used as much. And I think because there's just so much great data now on immunotherapy. So, in my role as overseeing research at Northwell, we've opened up 2 Merck trials recently. I'm still trying to get the faculty to sort of be aware of all, we're trying to really try to put every patient on a trial if we can. And that's really the best way we're going to learn. So Merck has a couple trials looking at combining TACE and immunotherapy in both locally advanced as well as resected patients. There are a few studies involving looking at immunotherapy combined with different radiation doses and fractionations. And I think I do see that, I do think that radiation, as you saw in the one study I outlined, can enhance the effects of radiation. And again, as we learn more and more about personalized profiles, like which patients have DNA repair pathway tumors, which ones are obviously MSI high, that's going to evolve, where maybe not ablative doses of radiation, maybe even just like a single fraction of radiation is going to be effective in enhancing the response to immunotherapy. So I think not sorafenib, but I think there's a lot of other exciting things on the horizon that are going to continue to be exciting to help this disease.
Wonderful. Dr. Rastogi, now your turn. Please introduce yourself.
Good morning, Dr. Herman.
Morning.
Excellent talk. What is because you have used the various fractionation schedule, like which is the best fractionation schedule? Is a 14.5, 67.5 in 15 or 125 in terms of the toxicity as well as in terms of the response rate?
That's a great question. And, that's where, if I always try to look at it, like if I'm the audience, you're saying, okay, this looks pretty cool, but why do you have all these different, like, why don't you just do 50 gray and 5 and call it a day and keep it simple, right? Why do you guys make it complicated as radiation oncologists? And I don't know if there's any radiation oncologists on the call. So you guys, I welcome any other comments on this question because it's a good one. The way I would boil this down is the following: is when you're dealing with the patient in front of you, there's factors that we take into account. And I'll be honest, I do think there's so much room for improvement. One thing that we're doing, and I'll just bridge for a second, in pancreas cancer, in our multi-D clinic now, we're creating one-page summaries, like very brief summaries that talk about the age, the performance status, what the patient wants, the size of the tumor, boom, 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 right? All these factors that very quickly help us decide what modality is best and then what fractionation regimen is best for that patient. Now I'm going to explain why. And I think, Sanjaya, what I want to do at Northwell is something that we can maybe work with them together, is to have the same thing for liver. And the reason for it is because it allows us all to have right in front of us. Because a lot of times when you have 100 people on a tumor board, everybody's presenting. Some people are like getting their kids ready for school and other people are eating. And so having something up front to say, okay, these are all the factors important for that patient. That way, everybody's tuned in, everybody's focusing and following the same thing. That then gets to your question. So if you have a patient that I'll just give you an example, right? If we have a patient that has early HCC, has a peripheral tumor that's 3 centimeters, has no comorbidities, and, let's say 4 centimeters. So 4 centimeters, because it's not perfect for RFA, right? Y90 would still be invasive. And the patient says, I don't want to do any kind of invasive treatment. I just, I want chemo. I want this thing taken out, or I'm open to other options. In that example, I would do a 3 or 5 fraction SBRT treatment. I might not even need to do fiducials because it's so peripheral. If it's dense, if it's necrotic, I can see it even on a non-contrast scan. And I would just recommend that I do it as easy and as quick as possible. And I have a lot of normal liver parenchyma. It's not a big tumor. And I can ablate it with, 50 gray and 5, or even I can do, a lot of times I'll do 45 and 3. Okay. That's that example. Now converse that with, I have a patient that already got Y90 in the left lobe. They have a Child-Pugh B. They have, congestive heart failure. They have all these other comorbidities, but they live close by. They have somebody that can bring them every day, and, they want to be safe. Okay. If I can do that in 15 fractions, I know from experience, and there's not a lot of data, but that's going to be more gentle to the normal liver parenchyma. If you fractionate, it gives a little bit more forgiveness if you have some setup errors. This is also important if you don't have a great machine. Like, let's say you have just just kind of a standard older Linac treatment. 15 is more forgiving because if you miss the tumor or a little bit of bowel gets in the way, not as big of a deal, like you're going to have some forgiveness. And then lastly is, let's say you have one that's invading right up against the stomach, and I want to give an ablative dose. In that case, I want to give 25 treatments. I want to still give 100 gray, but unfortunately that patient's going to have to come back 25 times if they want me to give an ablative dose. And that's also a patient that has maybe not good liver function, is older, but they live next door to the facility and they're okay with coming 25 times. I'm going to do it that way. So really, it's not scientific as much as it is looking at the whole patient, taking everything into account, and then personalizing that dose fractionation regimen. Is that helpful?
Yeah. So basically, it is the convenience of the patient as well as site of the tumor. What is the peripheral, whether it is very critical to the critical organs.
Yep. And I think, again, it's also, what else have they gotten before? Do you want to cover the nodes? I will say in my own practice, and Sanjaya knows this, if I can treat it in 3 to 5, I'm going to do it. If I can't do it in 3 to 5, almost always I can do it in 15 because I have some forgiveness there. I've only done 25 a couple times in my whole career. I find that 15 is usually safe enough. But again, there's a couple cases where I was very scared because they're 90 years old and I just wanted to be very careful or whatever. But again, most of my patients are going to get 3, 5, or 15.
Awesome.
Thank you very much.
Great. So let's move on a couple other. First of all, Prasun Jalal. Prasun Jalal is from Baylor, is a professor of medicine there. Dr. Jalal, please share your experience and see how you do.
It's a great talk, Dr. Herman. I think I had some common patients with you when you were here.
How's it going? Yeah, I recognize the name. It's good.
That's great. A wonderful talk. And actually, Eugene and myself have some common research projects together too. He's a great guy to work with, as you.
Yeah, he just I'm good friends with him. I just talked to him last night, by the way. So I'll make sure I tell him you say hello. And again, and thanks for I have to say on a holiday weekend for everyone, thanks for tuning in at 8 a.m. man. Appreciate it.
And so yeah, me, Eugene, and of course Ahmed Kaseb. We have common patients. And
Ahmed's awesome.
That's great. Now, it's wonderful talk. The biggest challenge is, as you mentioned, that it's kind of unrecognized. We all know that HCC is a very radiosensitive tumor. And me, Ahmed, and Eugene talk about it all the time. Still, we haven't standardized which way to go. RFA, which patient goes to Y90, which patient goes to the radiation oncology. And we do have radiation oncology all the time, as you and Anderson as well in the tumor board. So maybe I'm glad that at least like ASCO, ASLD is putting radiation as one of the modalities in the BCLC. But maybe we need to figure out. I mean, you guys are much more advanced in pancreas, but the liver is a little neglected site. So maybe need to figure out a combined way that how do you strategize and stratify these patients for radiation. For example, in the transplant world, there is always a concern that if it is a hilar tumor, whether it's a cholangio or HCC, whether SBRT is the way to go. But I have to say though, whatever patients you guys, our patients, combined patients gave SBRT, they did fantastic. And they had no problem in going for transplant. And the patient responded well and everything worked out. It's just for the hilar one, we are still worried. Yeah. And again, as I said, that we probably need to figure out which patient, traditionally we always push forward IR. And really, that's not the way to go. And because your modality is more non-invasive and maybe more tolerable and preferable by the patient.
Yeah, I think, you bring up so many great points. And I similar, I think, as I mentioned, the pancreas, example that we're doing right now with NCI of like getting, all these, we have 60 people now. And it's not, the purpose of that meeting is not to sort of look at like, okay, here's the randomized trials. We're actually digging deep and saying, okay, what are some of the single institution work that's being done that's awesome and needs to be brought to the forefront? And I think I'm thinking, and actually, putting together this talk over the last week is thinking about a little bit more is I think we need to do the same thing for liver. I think there's really good literature out there from Harvard and from MD Anderson and, Eugene. I mean, I'm a huge fan of Eugene. I think the work he's doing everything he can to get the word out there. Right. And, and admittedly, I mean, my career-wise, I've moved a little bit more towards pancreas just because of to be honest, with my other administrative roles. but my heart is still very much in these patients. Like there's so much more I think we could do. And I also was involved with Leo Chabot's case in China. And in that case even, and that's, I don't want to get controversial, but like, anyways, I better not say, but I'll just say that there's a lot more that if we can teach each other about our modalities and when it's best, as I tried to convey a little bit here. And I think what you're saying, I think that's the number one. The second though, is the ASCO guidelines. I think we need more than just guidelines. I think we need to your point, we need trials that are very forward thinking and really testing the right questions with the right endpoints. And that's not easy. So I would propose, and maybe we could talk about this offline, sure, but putting together a similar task force, focusing on exactly what you're saying is, what is the right trial or trials to really drive, the radiation question as part of the treatment within the spirit of better outcomes. And I think that would probably evolve to have one with immunotherapy, one maybe comparing with, IRE, one comparing IRE radiation and TACE or Y90. And I think there is one out there right now looking at that a little bit. And then finally, I think more of a personalized approach to care based on predetermined criteria and be smarter about how we do this. So I think the future is exciting, but to your point, we just need to bring it more to the forefront.
I totally agree. And again, in the offline, we can take it further and with your expertise and all the people around, involving both ASCO and ASLD.
And I think happy to work with you on that. Sorry, Sanjay, but yeah, happy to, my email's in there, and I'll reach out to Eugene to touch base with you too.
That's great. Yeah, we talk to each other almost every week. Yeah, great.
Awesome. Thanks for tuning in.
Right.
Yeah, I think honestly, the last couple of years when Joseph joined at Northwell, we started using radiation therapy for SCC more and more. And I think we're learning more and more. And as we learn more, and I think these are the things that comes up. Is it the radiation therapy, maybe the first choice rather over Y90 in some tumors? Or these questions are coming up. And I think we'll come out with more experiences, a clear pathway forward. With that, let me also pull in Dr. Maliakal from Nashville, Tennessee. Dr. Maliakal.
Oh, that was a great talk. And I had the same kind of comments as Preston had, but I had a little question. In terms of transplant patients, we always had this problem after radiation therapy, the M-resist with TACE and radiation is quite different post-treatment. And you talked about radiomics. Are there some criteria that have been established saying that, you can differentiate tumor recurrence versus radiation effect in the early 3 and 6 month post imaging? Otherwise, it's a fantastic talk. And I agree that SBRT is very underutilized and probably much easier to get through insurance than Y90, and probably has the same effect or better.
Yeah, no, so I think that was Eugene just saying, I texted Eugene, let him know you're wrong. I think the answer is yes. I think here's the limitation. And again, I'm a huge fan of Eugene, so I'll give him a little bit more kudos here. He just published, there's a couple of papers I wanted to get into the talk, and I was like, it's getting too long. So I forgot about that we had time at the end, but long and short of it, I think the first challenge is we don't have enough patients that we're treating to really know, right? And I think we're getting there, but, even Eugene, and I don't know if anybody here from MD Anderson, I don't think so. But, Eugene and I would still talk that even at MD Anderson, it's even though we have great data to show, it's at the end of the day, it's still very Y9, it's still very IR driven. A lot of the therapies are really determined by IR, and that's not a bad thing. I don't mean that at all in a negative way, but it's just that, we typically get sort of, I'll say, I hate to say this, but like kind of the leftover patient. So it's like, okay, you can't do surgery, you can't do this, but maybe there's a chance for radiation, right? So I think it's how do we get radiation more in the forefront for the right patient? And then I think then we have a better data to be able to do radiomics and such. Some of the work that Eugene's doing is very exciting, looking at, the SPECT imaging that I showed there. So So first of all, it's using imaging to understand what's the viable liver. That's important. And Eugene's done some of the great work on that and some of the trials that he's been working on. Some of it is looking at the tumor response itself with radiomics. And again, he's one of the ones in the forefront on this. I think the other areas, though, is looking at quantitative PET as a way to respond. There's some really cool, with MRI now, I think we're starting to learn how to assess better. And I think, but what's not happening right now is we should, in my opinion, be saying, okay, here's Mr. Jones, here's what the PET looks like, here's what the MR looks like, and then here's what the CT looks like. Based on radiomic evaluation of each of these, it's a very vascular tumor with this percent vascularity, this amount of fibrosis, and this amount of necrosis. Based on that paradigm, we think that X would be probably better in this patient. That's the degree. And they're a KRAS tumor or whatever, they have this mutation profile. And so I think it's radiomics with profiling, and then those other clinical factors that I talked to up front. So I believe the future is a dashboard. You have the liver in front of you, you have the different therapies, you have the characterization of the imaging, you have the biomarkers, you have the clinical factors, and you have what the patient wants. And then from that, you come up with criteria on how to drive this forward. And I think we have a long way to get there, but it's not impossible. We have the ability to get there. We just have to work together to make it happen. And we need our oncologists to also be aware of these therapies and learn about them better.
Great. I just want to
Thank
remind
you.
you, the audience, that in 2 weeks we have the next stop that is coming. Is going to be delivered by Dr. Meena Bansal. She will be talking about pathogenesis and treatment of hepatic fibrosis. Is reversal of cirrhosis a myth? So also see you all in June 11, and hope you also tell your colleagues to all join. And this, as you see, is a great talk and great conversations, and we're learning from each other and sharing our experience is important. And so I look forward to all to see you again in 2 weeks. Before I close, we have a couple more minutes, and I really want anyone else I left not calling in here, please come forward and introduce yourself, and if you have any questions, please feel free to come forward. Maybe I can ask to introduce a couple of people here which I do not know. Dr. Benugopal, Kota Benugopal. Would you like to introduce yourself? Anyone else I'm missing? Dr. Kutadia from Memphis, Tennessee.
Sanjay can ask for Australian.
Yeah, I forgot about
Australia.
Australia. Dr. What is Raj? Raj is not there.
He was there.
Hello, Dr. Herman.
Yes.
Yes.
Hey, it was a great talk. I really agree with you that SBRT that is very underutilized, and in fact, last week we had one patient that after exhaustion of all the like 2-time stays, Y90, now patient has a recurrent like metastatic lesion on the rib, and patient is looking for still an option and has not given up, and patient was offered an SBRT, at least showing some comfort. So I think that there is a role that is very underutilized, and we have to look for ways to probably look for the ways and where we can see that at the forefront and not at the very later end, as you described, and to have a more clear-cut pathways that is more kind of patient-centered. And I really enjoyed listening. Thank you. And I'm a hepatologist at the Methodist University Hospital.
Oh, great.
In Memphis.
Nice to meet you, and thank you again for again jumping in on a holiday weekend. I really appreciate it.
All right, with that, I think we come to the end of this meeting, and this talk will be has been recorded, and with permission from Dr. Herman will be available at the INEDCAST website, so you can go back and listen to it if you have missed anything and part of it. And the question and answer sessions, I hope you all enjoyed this. We're going to see you again in 2 weeks. And I would like to thank Dr. Herman for a great talk today. We really enjoyed and learned from you.
Well, I want to say thank you to you for putting together such an incredible, international program, and it's truly an honor, and it's really been great. And I look at it, I look forward to learning more from all of you. And my email is in the presentation. I'll put it here in the chat too. But Sanjay can forward it on everybody. So have a great weekend.
Great. Thank you all.
Have a great weekend. Thank you all. Bye-bye.
Thank you.
Bye-bye.